Dr. Hemant Sharma with his next case.
And by the way, by the time the computer is changing, any one of the here person will use a cemented stem in such case. And I will use, but anyone else, I can use rather. I'll not, I will use, I can use a cemented stem based on so many other conditions as well. And there have been couple of papers now which have shown that in a periprosthetic fracture of the shaft in him and using a long cemented stem, there is a technique how you fix the fracture and then do cement. So, in especially old days, yes, for fractures and the fixation of cemented stem can be used. So just for information. Not as a rule, but yes, it can be.
Sir, the abductors might have been the cause, weak abductors might have been the cause of dislocation here. So if we are immobilizing and not strengthening the abductors at the same time, that may again lead to dislocation. So what is your take? So we may strengthen the abductors while we are not mobilizing the patients.
Abductors might have, but I think he had a fall. So
Because we know that weak abductors in these age group patients are, if the component is not malpositioned, they may contribute to the dislocation.
basically, the rest is for soft tissue healing. That's why 3 to 4 weeks, and then definitely graded exercises are started.
I think we can go to the next case.
Next case.
Please.
Dr.
Thank you once again, sir. So I'll be going a little fast because it's a big topic. So I'll be talking about THR. In the finally, we'll discuss what are the take-home principles. Right. Yeah, again, nahi ja raha dost. So I had no experience of doing a THR in DDH in England. For 10 years I worked there and I did not see even a single case. And in the first month of my practice in India, I got a DDH. And of course, I had not seen, so had to take the bull by the horn. So learned a lot of things, complications and stuff. So this is there's no conflict of interest related to the talk and lots of complication. I've seen all except arterial injury. Thank God, I don't want to see that also. So I'm starting from complications. Nerve, femoral, sciatic, fracture of the acetabulum, femur, post-op fracture, intra-op fracture, dislocation, leg length discrepancies. And we are discussing how we're going to manage it. Femoral and sciatic nerve palsy is common. We feel that the femoral nerve will not be paralyzed. You will get away with the sciatic, but you'll have femoral nerve because you put a retractor in the front, so don't put it. And secondly, sciatic nerve is very close to the inferior part of the pubic rami. We will see the anatomy slide. One of my patients, very young, 24, and she had a sciatic nerve palsy. And I was very depressed. She's a very beautiful girl. The whole purpose was she could get married, walk properly, and luckily, little bit of a recovery. Finally, at 7 months, more recovery, and she recovered. You're not lucky all the time. Now, this one was an intraoperative fracture, so at that time I was not using a prophylactic wires. I always use a prophylactic wires now. It's an SROM stem with a Bantam cup. That is nowadays, that's my choice of implant. Immediate post-op, I never believe in keeping a patient non-weight bearing. If patient is non-weight bearing after a hip replacement, something is wrong, I'm not happy. Let's look at this. This was the bilateral DDH. One side there's a Wagner stem, other side Wagner stem did well. And next day in the ward, physio said he's having severe pain, got an x-ray, there is a fracture. Now this was not recognized during the time of surgery. The only problem with the Wagner stems I faced is it is really short and fantastic stems. I have got away, I don't use any bone graft now. I was putting bone grafts previously, the stem osteotomy side bone grafts. So I had to use a bigger stem, which is not ideal, but this saved me. So longer stem, fully coated cables and mobilized full weight bearing. There was no restriction. This is the second surgery, third day, next side operated, mobilized. So he sent a video, walking, and finally this man was happy. And these are his follow-up x-rays. Now prevent prophylactic cables, wires, SS, distally. Because if you have a fracture, it's not going to be complete like one of the speakers said, it will be partial fracture, unicortical, and they are stable, and I do not change the protocol. Even if I have seen some intraoperative hairline crack, my stem is good fitting, I mobilize them. And of course, if it's a long spiral going down, then you have to use a longer stem. Dislocation is again very common, because if you're doing a crow 4, you have a 22 head, your cups are not more than 40. I don't think so. I've got a 42, 44 cups. It's always 40 cups. 40 cups means 22 head. 22 head means, you know, all the philosophy. So this was the immediate post-op X-ray. I was very happy. I could get a primary fitting, bantam cup, SRAM stem, mobilized, very happy, good feedback, everything. Went to the airport, started to do namaz on the airport, dislocated. Calls me, I said, go to the doctor. He went to his country. I called the doctor, let's do a closed reduction. He did a closed reduction, but the other doctor said, I think I should revise something. I said, you can't revise, this is a stem, you will not find a head. The taper is very different, 11 by 13, it's not like 12 by 14, we get it everywhere. This I want, except Mrinal, everyone to answer this. This is a gentleman who had a DDH surgery in the past because he has seen this case. And so, straightforward, total hip replacement, did it. Cups, yes. Many times I can't get an uncemented cup because the bone is very soft, so I put a cemented cup. I'm a big fan of cemented stems, and I do not bother. Now this guy was long after the surgery I have done, and he is crying now. He said, what have you done, doctor? You have made my leg longer. And it was really long by 4 to 5 centimeters. Shall I go back in, do osteotomy, take the stem out? I got away without doing an osteotomy. Nerves are fine. I was very happy. What do I do now? Pardon? That's fine. There's no pain. You stole the show. So that's what I did. So I shortened the distal part, and there's a paper from Germany. So I did a supracondylar shortening, and it has healed. And this has happened 2 times with me. One was a young girl. So this X-ray is of that other girl. I did the shortening. And this is her walking video. She walked nicely. She has removed the plate a couple of months ago, but this is a follow-up of almost 4 or 5 years now. Right. Now this is one of mine. Bilateral TDH. Okay. And the right side, everything was done fine. So she had infection on the left side. I washed it. And right side went in for a non-union. So doctor has put a plate. So I saw her last month. This was almost 4 years ago I have done it. And I thought, now this is going to be a revision. So I asked her, she's fine walking. She said, I've just come to say hello to you, bought some khajurs for me, and I was very happy. I don't have to do anything there. So sometimes supervised neglect is an answer. So you need to know why the DDH fails. Multifactorial. There are some tips and tricks for acetabulum and for the femur. Take out the entire capsule. Now what I do my femoral shortening straight away. I cut the femur, hold the femur, bring it up. It's called turn down, turn up. And then I expose the acetabulum. There is no retractor required. If your lesser trochanter is in the acetabulum, you will need a femoral shortening. You will. And so therefore, why not immediately do an osteotomy of the femur and bring it up? Always have an image intensifier. I tell my anesthetist, please give me a full relaxation. Check the stability, standard posterior approach, 360-degree exposure of the acetabulum. This is a turn down. So I opened the hip, I cut the femur, prophylactic wire is there. I lifted the femur up and keep on excising the capsule from under the femur, go up till the acetabulum. You see the acetabulum very nice and clear. True acetabulum is so small, only little finger will go. You have got one chance, one reamer. So I used to use a reamer, now I don't use a reamer, I use a burr, and I was using a lot of number 7 grafts. So now I have stopped because I am getting a good fit. One number 7 graft I had removed because it was impinging. Young girl, she could not abduct, she was not happy because she was having problem in her sexual life. So I took it off. This was also done last year. Acetabulum 360-degree exposure, it's a very shallow acetabulum. So number 7 graft, now with experience I don't need a number 7 graft. Innovative reaming, don't use a reamer at all. Use a burr and keep digging the burr deep inside. Maybe one reamer you will need. And one cup is there, and tell your company guys, if this cup doesn't go, sorry. It will be a paperweight or you have to use it next time. Now, this is another one, previous surgeries. They have a lot of previous surgeries done. So that's a number 7 graft, well incorporated, cemented cup, Wagner stem, healed, no problem. I don't use anything. Now, this is, I don't know, fine. I think I'm just trying to show that acetabulum is lowered down. That's a false acetabulum. That's a true acetabulum. So only little finger will go in your true acetabulum. You've got one chance. And that's a number 7 graft. So what you do is, put that graft, put a K-wire, drill it and take a screw and put it with the machine. Don't try to do like this. Once you use your hand, the graft will move here and there, and so use a machine to do it. That's what I want to show. So acetabulum retractors, do not put any retractor in the front, femoral nerve will get damaged. Second thing is, DDH acetabulums have got thicker wall posteriorly, very thin wall anteriorly. Do not ream anteriorly, ream posteriorly. Do not take the reamer anteriorly, so that's a little different. Femoral, so this is just showing a cup and there is no number 7 graft. It was a good fit and fine. Once you have reduced it, femoral shortening. So you cut the femur, you try to reduce, see the overlap of the proximal and distal fragment, keep cutting it. The only problem with the S-ROM stem 22 head is that they've got only 3 sizes available. I think one, Rohan, how many heads have you got in 22 millimeters in S-ROM? 2. So if you have cut too much, you are gone. So, one. So he's right. So it's one head. So that's it. So if you cut too much, you are gone. If you cut too less, so you have to keep cutting little bit, 2 mm, 3 mm, and where you feel it is reduced, and believe me, leg lengths are going to be equal. And this is a femoral osteotomy, so do it. And I don't use any graft. So most of the patients are young and active, and they have got soft tissue contractures, bony deformities, bilateral DDHs. Now I'm not doing it, but previously I've done at least 50. Now I tell the patient, why are you coming to me? Every time I do a DDH, despite having done at least 200, I'm very scared. I can't sleep at that night. And inevitably, something or the other does happen. So this is a case in England, simple, not a DDH. My consultant cancelled this case because this patient, we we were planning to do this surgery. This was, the patient had Ehlers-Danlos syndrome. So we went back and told the patient we are not going to do a hip. So they use, okay, this is another one, previous surgery done. So I had to go from front, take the bone out, then go from the back and do an acetabulum. I've got a 10 years follow-up on this patient. She came for the second side last month. These are just identification marks. So that's a very shallow acetabulum you will see. Femoral osteotomy, and that's it. So that's what I was saying. That's the nerve which is deviated. So we put our inferior retractor, and you will find that there's a lot of anatomical variation. So don't put an inferior retractor also. So I normally avoid it. And keep everything ready. What you need: small cups, Bantam, Zimmer, Johnson, S-ROM, Wagner, and one distal fixing stem. So let us say you are in a situation where you have to put a bigger stem. Don't worry, proximal part is broken, let it be broken, just put some cables, work distally, you will get away. I have been in that situation before. That's another bilateral DDH I've done. Big lady. So again, as I said, full weight osteotomy, no restrictions. This was the time when I was doing bilateral DDHs also. Now I'm trying to, I'm a bit scared as I become more experienced. So this is a video which I always show. Leg length, offset and stability should be checked. The way to check the offset is you put your fingers in the neck of the femur, and what people do is they try to pull it down. No, move it up towards the sky. So move your fingers up towards the sky and don't use your biceps, just use your wrist force. So if you get that little feel that there is something is moving, that's a right offset. If it is very loose, short offset, you are short. Very tight, long offset, you are long. And check the stability of the patients in external rotation and extension. If it is interiorly unstable, flexion of 45 degrees, you should get 70 degrees of internal rotation. Flexion of 90 degrees, you should get 45 degrees of internal rotation on table. It should not dislocate. That's it. I'm just skipping these. This hip, then Ranavat's angle, we all do it. And thank you very much. I just skipped very fast because this is a topic I can keep on talking and talking. Thank you, sir.
Thank you, Dr. Hemant. Do we have any questions?
Okay, Number 7 graft, okay, don't go by the word. Basically, you're putting a graft at the deficient part of the acetobulum. It is called number 7 because Zimmer has an augment also called that augment. So it has the shape which you give, the way you cut it. So that's why it is called number 7. Basically, you just take that head, put it there on the top, put the screws. Even if it's a cemented, uncemmented cup, it stops, it gives some support because all the forces of the hip are going in that area. So it prevents,
It's the same as Peprosky femoral head.
Yeah, I have a question, sir.
Yes, please.
In your last
It's cut in the pattern of a 7. So basically,
in
the
your
head and
last
neck is
two
there, you
in
cut
your
off
last
that.
two pictures, I noticed that the Chandler retractor you have used a thread. So have you used for limb length discrepancy prevention?
Okay, I don't use Chandler's now because once in a hemiarthroplasty doing it laterally, I had a sciatic nerve palsy in my fellowship. So I was worried why. So I don't use Chandler's, number 1. Number 2, the threads are the rotators. So I put the rotators back. I don't use the thread as a measure of length, but not in DDH and other hips, I mark the center of head, GT, measure the horizontal and the vertical offset. That's only one way. Then pre-op, how much is the shortening? And in the lateral position, where are my two tibial tuberosities? And then I do an X-ray inside, where is my lesser trochanter of the normal side and lesser trochanter of the operated side. So that's how I check it.
So in your cases like that, in DDH cases type 4, when you bring down the trochanter from up, do you any face problem like pulling down the abductors down, or do you find differences?
You are shortening the femur.
The abductors with the trochanter and the attachment is...
Septic hips, yes. Pure DDH, no. Septic hips won't come down.
In operated DDH with previous osteotomies or a septic hip, it is difficult to bring them
Septic
down.
hip,
They are very tight. In a normal DDH, high riding hips, you do a subtrochanteric osteotomy, shortening osteotomy, it will come back.
Sir, how many femoral nerve palsy you have seen, especially in DDH and in normal cases also?
So I think in the first few cases, I didn't even know there will be femoral nerve palsy. The physios would say, sir, the knee is buckling, and I would say, yeah, epidural ka effect hai, don't worry, give a brace and let them mobilize. Then you find out just above the femur, there is a patch of numbness above the patella area. I think that's the motor sensory distribution for the femoral nerve. So if femoral nerve is there, I have not even written in the discharge summary there is a femoral nerve palsy. It generally recovers, I believe, because it's a purely motor nerve, and sciatic nerves, they don't recover. I have done tendon transfer where I do a bridal procedure. I've done for a few cases, but once you do such a good surgery and you feel you've done a primary hip and there is a sciatic nerve palsy, it just takes away your confidence why, what went wrong. And now I've come to the conclusion, using a diathermy near the Gmax, which you have to release always, is one of the reasons. So at Gmax, I put an artery inside and decrease the power of the diathermy. So diathermy is the one reason I've found, which probably could be cause of sciatic nerves, especially when you have done a short.
All the posterior approach surgeons, so we always think about the sciatic nerve. So I have encountered upon one case of mine, primary knee, hip replacement, undergone a femoral nerve palsy, having a quadriceps weakness, and the guy is troubling me a lot. Though it is an axonal nerve injury, it will recover, but it will take some time. So do not put your retractor too tight interiorly. Do not put your cautery towards that retractor. So if you encounter the femoral nerve palsy, they are not going to leave you either.
Yes. I think we are at the end of the session. Thank you, everyone. Thanks
Thank
for
you,
the
Mrinal.
wonderful discussion.
What a wonderful discussion. Now we come to the next session, Dr. Rakesh Rajput.
Start the next session. So may I also call upon my other colleagues, Dr. Ajit Kumar, Dr. Mrinal Sharma. Mrinal?
Arath.
Okay. Dr. Simon Thomas? Simon? Yeah, okay. And Dr. Rajkumar? And Dr. Ajit Singh. Ajit Singh as a panelist? Yeah. So we have Ajit Kumar and Ajit Singh. So I don't know if many of you are aware, Rajkumar is our Indian Arthroplasty Association Secretary, and Dr. Ajit Kumar is our incoming President of IAA. So we have the whole IAA representing here.
A great round of applause for all these people.
And yesterday you had IUA President-elect here. So the conference is very, very well looked after.
And the future IOA president is here, moderating. Future IOA president is moderating.
Okay. So I think I am the first speaker, if I can find where this thing is. Day 2 kind? Yeah. So I think I saw yesterday and also today that a lot of people are delving into post-acetabular fractures, and it's a very good thing because this fracture initial fixations are troublesome, and then actually coming back, and we love doing this, but it burns our fingers very badly many times, and these are young patients. So my suggestion is that this should be taken up by people who are really interested because of the age group. They are the active members of their family. So first time we failed, this time I think we should not fail. So it's a very important topic. So I'll just take through you. Believe me, none of these are very easy. All of them have slight difficulties. So plan your well, measure your leg length discrepancies we've been talking about. Do not hesitate to ask for CT scans. And I think our threshold for CT scans is coming down every year as we go. Keep all your inventory in good check, and I'll tell you examples why you have to be that. So you have bone deficiency, you may have cavity defects, or you may have a wall defect or a column defect, but luckily most of the time you also have the head which is there, but there are cases where even the head would have disappeared. So, but these heads are available, otherwise you have to go for a bone graft option. What implants? So you may need cemented implants. We are talking about the cup here. The stem side normally is the standard stem, whatever you want to use. Okay, but it's on the cup sides we got to talk about. So cemented cup, uncemented cup, augments, cages, and sometimes you got to go delve into even more than that. We'll come through that. So these trabecular augments, I think, are godsend to us, particularly for these fractures, and I'll take you through some of these. What approach to use? There have been occasional when we've actually delved into trochanteric approaches because of going on looking after both sides of the acetabulum, but generally whatever approach you are, most of the cases you're okay with it. But even if you are an anterior approacher or a hard hinge approacher, these are cases where you will be forced to go posteriorly for many other reasons. I'll elaborate some of them, but I think the go-to and workhorse approach for these fractures is posterior. There is no doubt about that. So Paprosky classification is something we've grown up with, but remember Paprosky classification was for revision surgeries, which was for defects, okay? In acetabulum, you will have defect, but the ilium, ischium and pubis are not same anymore in alignment. So you have something more than a defect. You have malalignment in the whole pelvis. So Paprosky will not be working on you that. Luckily we had AOS classification. Paprosky never mentioned about a pelvic discontinuity, which AAOS actually mentioned that. The trouble is, AAOS also is for revision surgeries. It was not meant for the pelvic fractures. So we were always actually in trouble with not having a good classification till our own Dr. Sain came over and actually gave us a classification. So I'll just tell you about the Dr. Sain classification. This is what we now actually use as a pelvic acetabular surgeons. So your type 1 fracture is basically a circumferential fracture, okay? So you have the whole cavity there, but it's just been expanded a bit. So you just need a bigger cup. So the solution also comes from this classification. So type 1, you just need a bigger cup. Type 2, you have a wall fracture. So what you need in this wall fracture, either you can put back the wall. If the head is damaged, you can replace the head. Or if the wall is deficit, you can use your head as your augment for the wall and then actually fix it well. So solution coming from your classification. Type 3, which is the posterior column fracture, okay? So now column fracture could have united or malunited and could have been undergone a fibrous, very strong fibrous union, or 3B where there is a non-union. So if you have a good malunion posterior column, you can just put a cup onto that. If it's non-union, you will have to plate it. So see, the classification is giving you what you should be doing. Type 4, which is involving both the columns, even the transverse fracture will fall into it. You can have pelvic discontinuity. So if it's strong fibrous union, go ahead and put a cup. You are fine with it, even if it's both columns. In 4B, where you have the discontinuity, but you also have what we call as non-union. Here, you will have to fix one of the columns, which is the posterior column. So again, the approach will be posterior. So again, giving you an idea of what you should be doing. If you have a defect inside, you should be filling that defect also. So you see, this classification is leading you to the treatment. In type 5, which is the anterior column, sometimes the anterior column is not that important. You can go ahead and actually put a cup. But if it's a large chunk of anterior column coming onto the superior side, you need to fix that well. So this classification is taking you and guiding you how you should treat. So very important classification. So let's look at the first. This where the posterior wall is absent. So this is type 2 Dr. Sen classification, okay? So what do we do here? So normally we want to fix this. I have fixed wall fractures even at 1 year of age, but the head should be good. If your head is just dislocated and not rubbing against. So if you see this one, it's actually coming in, going out, coming in, going out. That's why this guy's been actually walking over it. So he's been walking over this for 4 months. So what he's done is he's completely damaged the head. If this was continuously dislocated, we would have had a more chance of salvaging this head. So what we do our CT scans just to see what the wall is like, because at that time I don't know about the head. So at this time we look at, so there was already, from the scans we were looking at a very comminuted posterior wall, but when we went inside we realized that this head is actually quite scratched up. There is indentation on the head, so we realized that we cannot salvage this. We went ahead and actually do a break. So my one suggestion would be always have a C-arm on your table for these fractures. Whatever, even for normal THR you don't do, for these ones, because of the alignment issues, you don't know what's happening. You need to put this cup back and actually fix that wall fragment back into the place. So if the wall is missing, you need to get your femoral head graft, cut it, make a wall there, fix it, put your cup. So these are straightforward, these are type 2 Dr. Sen. And you get a good outcome from these. The next one comes where you have fixed the acetabulum, but there is a avian happening. Initially it looked very good. Remember, we only talk about avian of the head in normal circumstances. In acetabular fractures, you don't have avian only of the head. You also have avian of the acetabulum. So what happens, even the acetabulum starts crumbling up. So this is what happens. You have the whole cavity here, but it's expanded. So this is our type 1 scenario, where you have everything around you, but it just expanded. So you just need to put a slightly bigger size compared to the other side. Okay, so slightly bigger cup. The other side will act like a good template. Again, doesn't matter what stem you use, the cup will be slightly bigger cup. Then you have defects, which were like transverse fractures to start with. Somebody put in this traction device for 2 months. Believe me, you should never put these pins. Never ever put these pins as reduction tools, for traction purpose. For an operating surgeon, this is godsend tool, but not for just pulling traction. So please, one thing if you take away, don't put these traction pins on the trochanter lateral tractions. Don't do that, please. You bugger up the next surgeon's approach. So this fracture migrated. First it had a 1 plate put in, then he had a 2nd plate put in, still it dislocated. So this is how we received him. Now if you look at this fracture, ideally I should have come back to the teardrop, but there is absolutely no bone out there. So I accepted a slightly higher hip center. It's a drawback, but I tried to get my screws down into the at least pubis. I couldn't reach the ischium from there, but I tried to get into the pubis. So we just managed about this. We put a small superior augment, just about taking the cup, but this is not an ideal situation. We should try and get these cups to the ischium, whatever we can. Sometimes the contractures are so big, it's not letting you come in. So here we have a 6-month-old lady in early 40s, road traffic accident, on a wheelchair, not walked ever since. But look at here, now you have an expansion. So you have superior to inferior expansion of the acetabulum. So we have a defect. We have a posterior column which has migrated in. So the posterior column defect is there, and you have a wall defect. So in these cases, when you try and reconstruct, you need to use augments. And you need special augments for this because you now have a superior to inferior migration, column defects also. So you need column augments or buttress augments as we call them. So you need to put this and then go ahead and use your normal. So this only a small part. As long as you've got 70% coverage, you can go ahead and use a normal cup in these cases, but you need to augment them. Okay? And this is how she's walking. This is how she's walking. Right? So I'll skip over that. Next comes pelvic discontinuity. So sometimes people worry about what is this pelvic discontinuity. Basically your superior hemipelvis is discontinuous, bony with the lower half of the thing. In pelvic trauma, the other option is that the inside of the pelvis, the lower part might have migrated inside. So you have 2 problems now. You have defects and you have discontinuity. So here we have to do something to both of these. I'll give you a couple of these examples. Right? So we'll look at this case, 31-year-old lady who fell from height. This was a suicidal attempt. She survived, but she had lots of other injuries for which the actual acetabulum got neglected. So 4 months down the line, she comes to us, and that's how she looks like. So the whole hemipelvis, as I said, has migrated in. It is discontinuous. The question now is, in this area, has this united or not? So to find that answer, you need to do your CT scans. If you see the head subtraction sequence, you can see a clearly line running. But you still can be hopeful. There could be a very strong fibrosis, I said. So strong fibrosis is as good as union in all of these cases. So you can just bone graft that and it will tide you over. So we go in, as I said, the go-to approach for these will be posterior. You might worry what my catheter there is doing. So I had a superior gluteal arterial bleed because of the whole migration inside. All anatomy is distorted. So I had a bleed. Normally I know where my superior gluteal artery is, but in this case, we didn't know it. So we actually ended up rupturing it. Just put a catheter in there. Don't try to put gobs out there. You will just have to keep waiting 20, 30 minutes, just trying to control this bleeding. Put in this Foley's catheter, inflate it to all 30 ml and just put it aside and start working around it. You won't waste any time in that. Then you do your head, split it out. So initially I put in the small remus and cup and see if there was a fibrous union. I realized there isn't. This cup was very loose. So again, took back, put a plate in. So you got to now plate. So this is how the classifications are helping you. So put in a plate, stabilize your column, and then go ahead and put your cup in. So you get a very good, and put bone grafts behind your cup. You should not leave empty spaces anywhere. So you have good amount of bone here. Luckily, many of these cases you will have. So put bone graft out there. So another case, which didn't start off as a pelvic fracture or post-acetabular fracture, but this is rheumatoid arthritis. 9 years ago, operated in our neighboring country. And gradually you see this hip was already getting protrusive right in the beginning. Even in the post-op x-rays, down the line about 2-3 years, he was protruding. At that time, he was asked to revise, but patient refused. So by the time he's come to us from that country, you see where the head is now. So we were discussing these cases yesterday that, if you have this, please do CT angios. Know where your blood vessel is. So we did a CT angio for this one. It was in close proximity, but there was still a gap. The membrane behind this was still very much intact. So you could go in. Question is, you need to be ready for the next hard constraint. Can you get away just by the rim fit? So we were ready for the rim fit. But by the time we got it out, we realized there's an absolute pelvic discontinuity. This is happening on the table. So there is no question of hard fibrosis out here. We have a frank pelvic discontinuity. So either you need to go back and plate your posterior column, but in these ones, because of being rheumatoid, I didn't rely too much fixation. Straight away went with a cage. And also this point we discussed yesterday, the lower part of this cage should be going into your ischium. It should not be floating outside. At least put a screw in. If you are still putting the lower part of your flange out, put a screw in, or better, put the actual whole flange in. It works like a fixation, right? So put your cage in and you get a good result from this. Now there will be cases which are even beyond redemption, like one of these cases. So I don't know if this one will work. Yeah, so just have a look at how severe some deformities can be. So it is beyond whatever available things you have armamentarium ready-made for you. So we templated that we just cannot go ahead with any sort of reconstruction. He's a young guy, he's in his 40s. So what do we do for this? So first thing is narrow the defect. So bring it down. So we use an extended iliofemoral approach for this, brought it down to some sort of remnants, tried to heal the top bit of it and made that defect smaller. But when I did a post-op CT scan, I realized even now it is beyond the scope of even for a cage. So what do we do now? And the answer is, at this stage, you start thinking about custom-made implants. So at that time, this is about 7-8 years ago, we didn't have too much of customization in India. So I got in touch with one of the US companies, started sending him CT scans, started even giving him my inputs, because what they do is they just make something big to fit in the acetabulum. I said, we need to anchor it. And what is the good part in this acetabular fractures? It's the area at the SI joint. That is where you need to anchor your fixation. So once we got that, we actually managed to get the device and then fit it. So remember where you're fitting in, just where the SI joint. That's the only remnant good piece of bone which is available. So you can actually, take this on. So my suggestion is we are getting better, but there still are cases where I think 3D mapping and 3D printing of the implants are very much essential. So you have all this now, but still there will be cases where even these will not actually overcome to you. So my suggestion is post-pelvic fracture THRs are difficult, not impossible, they are difficult. But there is light at the end of the tunnel. We have very good implants coming in. We have very good augments coming in. We even have 3D customizations done. So your implant should be stable on the table. That is very important. And please bone graft any defects which you come across. You have head in most of the time. Otherwise, rely on thing. And be ready for the next higher implants, at least till cages. So because otherwise, if you don't do, you just might be left exposed. So make sure you don't end up like this. Okay? Thank you very much.